Welcome to Essentials of Acute Care. I am Dr. Sunil Garg and today I am going to discuss choice of resuscitation fluid. Means which fluid should be chosen when we are dealing with the critically ill patients. Intravenous fluids are the most common intravenous treatment given to any critically ill patient in the hospital, and the main purpose of its administration is to maintain or to increase the cardiac output so hypoperfusion can be alleviated. Intravenous fluids affects the cardiovascular, renal, gastrointestinal, coagulation and the immune system, and the differing fluid has different composition which in turn affects the risk of acute kidney injury and death for critically ill adult patients. For a long time, intravenous fluids were considered as safe, but due to the associated risk, they are now viewed as a drugs. And before administration of intravenous fluids, dose and composition should be selected based on the best available evidences and the risk-benefit ratio analyzed. The acute illness will determine the nature of fluid lost, and the fluid lost can be from whole blood to almost pure water. So, the ideal fluid for the resuscitation vary from patient to patient depending on the underlying condition. So, individualized therapy. Fluid resuscitation is required in critically ill settings in the patients who has dehydration, hemorrhage. Hemorrhage can be traumatic or non-traumatic, sepsis, trauma, burn, and pancreatitis. And here it is important to remember that both inadequate and excessive amount of the fluid administration may lead to poor outcome. Now we will briefly understand about types of fluids. There are two different types of fluid. One is crystalloid, which are solutions of electrolytes in water, and another fluid is colloid, which are large molecules dispersed in crystalloid solvent. The most common colloids which is used in the intensive care unit is albumin, while the most common fluid which is used for the resuscitation is isotonic fluid. Isotonic fluid are of two types. One is normal saline and another fluid is a balanced fluids. Here it is important to understand that hypotonic fluid is not used for the resuscitation in intensive care unit. So what evidence is available when head-to-head comparison of different fluids was made? The risk of kidney injury and the death appears to be greater with the semi-synthetic colloids compared with the crystalloids. Semi-synthetic colloid means dextran, gelatin, and hydroxyethyl starch. The incidence of death, new renal replacement therapy, and persistent renal dysfunction was lower with the balanced crystalloid than normal saline, and this effect was greatest for the most severely ill patients, patients who received the largest volume of fluid, and patients with the sepsis or septic shock. It means in the patients of septic shock, balanced crystalloids are better than normal saline. Analysis suggested a potential harmful effect of albumin in patients with the traumatic brain injury, while albumin was beneficial for patients with the sepsis and septic shock. Since semi-synthetic colloids may increase the risk of death or acute kidney injury compared with the crystalloids, so effectively crystalloids are preferred over colloids. And in terms of balanced crystalloids, it reduces the risk of death, renal replacement therapy, and persistent renal dysfunction compared with the saline. So, effectively, balanced crystalloids are the first line for the fluid resuscitation. But there are few conditions where normal saline is preferred over balanced crystalloids, and these conditions includes patients with the traumatic brain injury and when the patient has hypovolemia and alkalosis together. In terms of use of the hypertonic saline, it represents the first line treatment to temporarily reduce elevated intracranial pressures in patients with the traumatic brain injury. Bleeding patients need blood, and if the patient has significant hemorrhage, such patients should be transfused with the blood and its component. And initial crystalloid administration in such patients should be limited till the time blood and its component are being arranged. Consider albumin during resuscitation of sepsis and septic shock when these patients have already been resuscitated with crystalloids and patients need more fluid. Consider hypertonic saline in traumatic brain injury to reduce intracranial pressure, though outcome benefit has not been seen with this approach. Albumin is contraindicated in traumatic brain injury as the hydroxyethyl starch in sepsis and others, those who are at risk of acute kidney injury. So to conclude fluid resuscitation, a reasonable approach would be to use primarily balanced crystalloids which are ring-lactate, Hartmann solution and plasma light. Consider 2 to 3 liter for initial fluid resuscitation of hypovolemic or distributive shock. Use blood and its component as appropriate in hemorrhagic shock. Use albumin in initial resuscitation of sepsis and septic shock. Use normal saline and hypertonic saline in traumatic brain injury. Do not use 5% dextrose for resuscitation of adult critically ill patients. Do not use semi-synthetic colloids for resuscitation in critically ill adults. And do not use albumin in traumatic brain injury. Thanks for watching this informative video. If you have any suggestions, comments or feedback, you can write down in the comment section box. Once again, thanks for watching the video.